afternoon, and welcome to this second European Virtual Roundtable on Simeox therapy. First, let me introduce myself. My name is Laurent Morin, Medical Affairs Director of PhysioAssist. And as you know, airway mucus obstruction starts very early in patients with cystic fibrosis, causing air trapping, abnormal lung perfusion, and lung function decline, and even before the onset of respiratory symptoms. So key success for bronchial drainage is to remove not only proximal secretions, but mucus plugging in distal airways. Aim of these roundtables are to share best practice on Simeox therapy for each step of CF management. So I will be responsible for hosting this presentation today, and I'm glad to welcome the speakers who will talk about the second topic of these roundtables, mobilization of mucus in the bronchial tree with Simeox therapy in CF patients, the benefits of planned hospitalization. So let me introduce the speakers now. Dr. Tereza Doušová, pediatric pulmonologist, and Mrs. Hanna Chmelarová, respiratory physiotherapist from Motol University Hospital and Charles University in Prague, Czech Republic. Dr. Justyna Milczewska, pediatrician and pediatric pulmonologist, and Natalia, Jeneralska, respiratory physiotherapist from the CF department of Institute of Mother and Child near Warsaw in Poland. Dr. Hanna Schmidt, pulmonologist from the CF Center of University Hospital in Ulm, Germany. So Dr. Doušová will moderate the session with me. And now, as our first guest, Dr. Doušová will present the first case report. Dr. Doušová, it's your turn to start. You can share your screen now.
Good afternoon to everyone. We would like to present our experiences with Simeox during the planned hospitalization of our patients with cystic fibrosis. We are going to share this presentation together with our respiratory physiotherapist, Hanna Chmelarová. We would like to present you a case of our 18-year-old male boy or a patient with cystic fibrosis. As to his medical history, he was diagnosed with CF at the age of 5 months. And as you can see, he already had the protracted dry cough, right lower lobe pneumonia, and there were signs of pretty severe malnutrition during that time. At these days, the newborn screening program was not available yet in our country. So his sweat chloride test was highly positive. His genotype is he's homozygous for the delta F08, and he's pancreatic insufficient. On this slide, you can see the photography this is the latest photo. And this is the photo from the time when we started the Simeox therapy during this planned hospitalization. He was already colonized chronically by Staphylococcus aureus, unfortunately even with the Pseudomonas, intermittently with the Stenotrophomonas maltophilia. And we recognized the exophilia dermatitis in 2020. That was after this planned hospitalization with Simeox. And we intermittently treated him due to his aspergillus infection as well. The situation was a little bit complicated even due to the ABPA, which was treated during the year 2019 with pulses of systemic steroid therapy. There were signs of malnutrition and growth impairment at that time when we started the Simeox therapy. You can see that his body mass index was 15, and you see his weight and height at the time. On this slide, you can see the CT scan where there were signs of mucus plugging and the bronchiectasis and even, even the atelectasis of the right lower lobe. And the patient was expectorating and producing a lot of sputum. his strength of his pulmonary lung functions in terms of FEV1 values. So you see that his lung functions were declining slowly since 2018, and during 2020, here is pointed with the blue circle. That was the time when we initiated the Simeox therapy. At the time, his medications were pancreatic enzymes, vitamins, and probiotics, and we started later the Orkambi therapy in February 2021, and his regular inhalations were 6% saline solution with salbutamol as the premedication, and the long-acting beta-agonist agents, and pulmozyme once per day since 2013. So Anna is going to continue about the information of his respiratory physiotherapy.
So, hello, here comes the physiotherapy part, and I would like to tell you something very briefly about our patients' established home respiratory physiotherapy sessions. He usually starts with upper airways irrigation, which is very important for this particular patient because his upper airways are usually very congested. Then the upper airways irrigation is followed by inhalation of the medicaments mentioned before. And I, as a physiotherapist, usually focus on correct inhalation technique and positioning during inhalation, and mainly on his left side because of his hyperventilation of the right lung. The airway clearance techniques are usually performed with PerioPEP, and I think it's probably the only device he uses regularly. So as for Simeox, our patient's first experience with Simeox was in February last year, and it was during hospitalization for the acute exacerbation. And during the hospitalization, we could see excellent clinical effect. So based on this experience, we asked our CF patients organization to lend him this device for a month. And as a result of the benefits, we also offered the family to the 2-week hospitalization on our rehabilitation ward. And I would like to also notice that, or to say that we also offered this hospitalization to the family because we also wanted to take the patient out of his, let's say, non-ideal family circumstances in terms of cooperation. So the key problems we focused on were mainly mucus stagnation in his right lower lobe, then decreasing spirometric parameters, limited chest expansion based on measuring respiratory amplitudes, bulging of the abdominal muscles, as you can see in this first photo here, and overall postural dysfunction. So during the hospitalization, we provided physiotherapy twice a day. The first session was usually physical therapy, and we were focusing on correcting posture and improving muscle imbalances. And we were using mainly manual therapy and also exercises for engaging his core muscles. The second therapy was respiratory physiotherapy, and we focused again on inhalation technique, thoracic expansion exercises, but mainly we performed therapy with Simeox. The therapy was very well tolerated by the patient, so we are able to perform two therapies with Simeox daily, and that means one was provided or under supervision of the physiotherapist, and the second one, the patient was able and capable to perform it by himself. So as I said, therapy with Simeox was performed twice a day, and we were using these positions. Here you can see on the left, upright sitting and then reclined sitting position, then lying on both sides, and then prone position. During the patient's exhalation, we were guiding the chest to help the patient to exhale properly and to reach the expiratory reserve volume faster. The power was initially set on 100%, and it was decreased gradually during patient's exhalation to 25% to maintain the signal within the peripheral airways. And as I said, it was very well tolerated by the patient. So here you can see the results. And as you can see, the improvement was mainly in the peripheral airways, MEF 75, 50, and 25, and also his vital capacity increased quite a lot, we would say. So here we can see a comparison before and after the 2-week hospitalization period. And I think that all of us can notice the difference mainly in his in the position of his shoulders, which are really protracted here in the first one photo, then and shortening his pectoral muscles. And I would like to also emphasize the position of his chest, which is, you can see it, which is quite in a cranial position here. And in the second photo, we can see how his abdominal muscles are engaged. And I think it's even more obvious here in these photos. The first one, we can see the protraction of his head, shift of the chest backwards, and a bulging of abdominal muscles. And it's significantly improved in the second photo. So just to sum it up, we managed to enhance the spirometric parameters. We improve airway clearance, which is, I can tell it because I could see the patient that he was not able to cough something out in the last days of the hospitalization. And I could also the fluent chest expansion, improved function of abdominal muscles, and straightening of the spine, and released muscle imbalances. So that's all. Thank you for your attention.
Thank you very much for this great presentation. So let's move now to the second case report, and Dr. Milczewska and Mrs. Jeneralska will present this case report now.
Hello again. Thank you very much for inviting us. And me and our great physiotherapist, Natalia, we will present a case of a boy who benefited very much from a planned hospitalization and individual physiotherapy training introducing Simeox. It is a 13-year-old boy with cystic fibrosis diagnosed through neuroscreening. The boy has a mild bronchopulmonary disease and chronic Staphylococcus aureus infection. He also has several complications of cystic fibrosis and comorbidities. For example, since 2017, there was a problem with increased concentration of total IgE. The boy was diagnosed and treated for toxoclerosis. However, this elevation was still observed. So we started to observe him for allergic bronchopulmonary aspergillosis. However, he did not meet the criteria, so he didn't receive the treatment. However, it was also complicated by pulmonary infection with Aspergillus fumigatus, but it was rather invasive infection, and it was diagnosed in October 2018. The boy was first treated with itraconazole. However, these changes were quite large, and we suspected fungal etiology. So we started to treat him with voriconazole with good effect. Also, in January 2020, the boy had very serious pulmonary exacerbation. It was initially treated with intravenous amikacin and ceftazidime. However, it was complicated by atelectasis with pleural reaction, and we changed treatment to intravenous meropenem and clindamycin, and in addition, inhaled colistin. During this exacerbation, he underwent bronchoscopy, and in the bronchoscopy, we observed intense inflammatory changes and a large amount of thick respiratory secretion. And this was his X-ray in the beginning of this exacerbation. In following 3 X-ray examinations, we observed gradual regression. Also, the patient has cystic fibrosis, liver disease, and sinus polyposis. Right now, we are planning endoscopic surgery in this patient, and he's waiting for it. And also, which is very important, there are some psychological problems. The boy, at the time, and there were some psychological problems. The boy used to be poorly cooperative, rebellious teenager, and he was wary of daily physiotherapy, and we knew that he doesn't perform physiotherapy properly. Here you can see his spirometry parameters in terms of FEV1 and FBC. And as you can see in his stable period, his FEV1 is between 80 and 90% predicted. This was this serious exacerbation. And after this exacerbation, fortunately, he returned to the values before exacerbation. And by the end of 2020, the boy was admitted to planned hospitalization, which lasted for 4 days. At the time, he was in stable condition with no clinical features of pulmonary exacerbation. However, there was still a serious problem with cooperation with this patient, and we decided to use Simeox in this patient to train him how to use it during this hospitalization. And his parents declared that they will get the device so that he can use it at home. And he started the training. And now, Natalia. We start with physiotherapy in hospital. Our patient need our help with physiotherapy because at home his physiotherapy wasn't so good that we would like to be. So we speak about Simeox, and he said that it will be okay to try. And when he started working with Simeox, it was very good cooperation with us and with Simeox. How it looks. First, our patient need inhalation formoterol twice a day, then 5% hypertonic salt nebulization twice a day, Dornaza alpha nebulization once a day, drainage with using Simeox twice a day, and drainage with using PEP and oscillation PEP once a day, and physical activity. When we start working, our schema of a day looks like here. Morning, formoterial inhalation. After 15 minutes, nebulization with hypertonic salt, and then drainage with Simeox. we using Simeox and positive expiratory pressure PEP system, because he said that he feel better his mucus when we used Simeox with PEP. So we tried our physiotherapy like this. Afternoon physical activity outside, bronchial drainage using Simeox and PEP, and then nasal alpha nebulization. On the evening, pulmonary inhalation after 15 minutes salt, and then he using OPEP and PEP because it was evening drainage, and he stay in hospital, and this physiotherapy wasn't with physiotherapists. So first morning and afternoon physiotherapy we make with our patient. Evening physiotherapy he made by himself. When we start working with Simeox with our patient, first we learn him to exhale correctly with glottis open. It was a big problem for this patient. So we start working and learn how to do this, and we try to find position, and the best position for why was positioned like this on photo. And we start with 10 exhales in series, 6, 8 series depending of the amount in airways, and we start 25% and 50%. First two series we use 25% of power, then next series 50%. Why we don't use more? Because it was very big problem with glottis, and it was vibration about his mouth, not in his chest. It was too much for him. And between we use positive expiratory pressure. And when he go home, we try to one more time. When he go home and he used Simeox at home, he do like this at home, but we change only time at home, because on the morning and the evening he used Simeox, but afternoon at home he used PEP and PEP series, how many series, how many exhales in series, and power of Simeox. It was the same like we used in drainage in hospital. And after discharge, he started using Simeox at home. He came to our center after 2 months in March 2021, and we observed improvement of his general condition, also of his physical efficiency. The intensity of cough during the day was reduced when we compared to previous months. And which is very important, we observed also increasing motivation to perform daily physiotherapy. He not only started performing physiotherapy with Simeox regularly, but also he changed his attitudes regarding physiotherapy. He started to like physiotherapy. And we discussed the correctness of this physiotherapy, which we thought was very good. And we also observed significant improvement in spirometry parameters. For the first time, he had FEV1 above 100% predicted. Before Simeox, it was around 90% predicted. Now it was 104%. And in conclusion, I would like to say that it was a very good idea to implement Simeox in this patient in hospital during individual physiotherapy training, because on one hand, this individual training gives the possibility of personalized, we can also say tailored therapy, because we can select the optimal set of parameters for a given patient, and we have some time for it. And the correct drainage technique learned during this 4 days of hospitalization gives better results, which translates into better well-being, and also encourages further work, which was very, very important for this patient, because he started performing physiotherapy regularly, and he started to like it. And thank you very much for your attention.
Thank you very much for this very nice presentation. So we had two very well documented case reports in children. And now Dr. Schmidt will present preliminary data from a pilot study in adult CF patients. So Dr. Schmidt, you can share your screen now.
So I'm happy to go on with the last presentation for today. I would like to present the results of a small study we performed in our CF department that basically aims on short-term effects of Simeox therapy in adult CF patients. So the aim of the study was basically to assess if there are beneficial effects of Simeox therapy when it's used as a mucus mobilization tool in patients with cystic fibrosis. We based the study on 3 main hypotheses, which we addressed in the study. So the first was if mucus mobilization with Simeox can improve lung function. This was assessed with conventional spirometry. The second was if Simeox can improve diaphragm mobility. This was investigated with an ultrasound-based analysis. And last, we expected Simeox therapy also to affect sputum properties, and we therefore measured sputum viscosity and DNA concentrations in spontaneous sputum samples. We included 21 adult patients with CF during a stable phase of lung disease. They were recruited when they were seen for a regular checkup in our CF department. And we excluded patients, you see this on the right, with acute infection or exacerbation, also with unstable cardiovascular disease, so patients who had recently pneumothorax or relevant hemoptysis, and also pregnant patients. In the table, you see some baseline values of our study population. So we had mostly young adults with a mean age of 30 years. They were half male, half female. And when we look at the spirometry data, we see, looking at FEV1, that we had a quite heterogeneous group ranging from only 35% of predicted FEV1 to patients with normal lung function. So after recruitment, we of course obtained consent from patients, and they started the first study sessions with ultrasound of the diaphragm, followed by spirometry, and they were asked to provide us with a sputum sample, a spontaneous sputum sample if possible. Afterwards, they had the actual therapy session with the Simeox device together with a physiotherapist, and after therapy, we did the same examinations again in the same order. So first diaphragm ultrasound followed by spirometry, and we collected a second sputum sample. When we planned the study, we considered that patients first may need some time to get used to the novel device, and therefore all of them joined in a second therapy session within a few weeks, where we did exactly the same with the same workflow. And at the very end, patients additionally completed a questionnaire reflecting their own opinion and experiences with the therapy. Now I want to go just through our main hypothesis and show you the respective data. And we start with the effect of Simeox on lung function parameters. So patients did spirometry before and after Simeox therapy. And when we look at the data here, FVC, FEV1, and MEF 25, 50, and 75, and we compare the values before and after therapy, we found no difference for lung function parameters. Then we come to the second point, the effects of Simeox and diaphragm mobility. Here, I first would like to briefly introduce ultrasound-based assessment of diaphragm mobility to you. It's a method that allows direct functional investigation of the diaphragm. Is it originally known from intensive care medicine? There it's used to assess diaphragm dysfunction in intubated and critical ill patients. However, in recent years, it had also been experimentally used in COPD patients, and there it could be shown that diaphragm excursion correlates with disease severity, and it had also been demonstrated that physiotherapy techniques can improve diaphragm mobility, and in some studies, diaphragm ultrasound was even more sensitive to changes after physiotherapy than spirometry. Therefore, we were interested if diaphragm mobility would also be changed in CF patients after Simeox, as this has not been studied in CF patients so far. So for the measurements, patients were in a lying position with slightly upper body elevation. We waited until they were relaxed and breathing at rest. And then the diaphragm was imaged in the right anterior axillary line. You see this here in the B mode image. You see the liver, and the diaphragm appears as an echogenic structure just behind the liver. And for functional assessment, we did M-mode measurements, and they basically reflect the diaphragm movements during breathing. You see here in this M-mode trace. For each individual breath, we then calculated 3 parameters. So the maximum amplitude of diaphragm excursion and the slope of the amplitude increase during inspiration and during expiration. When we now look at the results and we compare the values of all participants measured before and after Simeox therapy, we see that the maximum diaphragm excursion was slightly but significantly increased after Simeox therapy. The slopes of inspiration and expiration were not significantly affected. But to sum up, the results show that Simeox resulted in certain improvement of diaphragm mobility. Our last hypothesis addresses sputum properties. It's generally assumed that oscillatory devices such as Simeox and others have a kind of mucus liquefying effect and thereby facilitate sputum expectoration. There are some in vitro studies which could show such effects in vitro when they applied oscillations or vibrations on a mucus sample. However, in vivo studies could not clearly confirm this, as those data results are more contradictory. In our study here, we used a microscopy-based assay to assess mucus viscosity. It's called FRAB, stands for fluorescence recovery after photobleaching. I will not go into details here regarding methods, but now you need to know that a half-time of recovery normalized to the half-time of sodium chloride solution, this is what's shown here on the graph on the y-axis, directly correlates with viscosity. And when we look at the results and compare the values we measured in the sputum samples collected before Simeox and after Simeox, we see that there is a marked increase of sputum viscosity. At first glance, this might appear surprising, as we heard that oscillatory devices are considered to reduce mucus viscosity. However, here we analyzed two separate samples, so we cannot address the question if the direct physical impact of oscillation affects mucus viscosity, but we can say that the samples collected after therapy have different properties, have a higher viscosity than the samples collected before therapy. As a second parameter, we determine DNA concentrations in the sputum. It's well known that mucus DNA is mainly derived from neutrophil granulocytes, and it's also known that a number of neutrophils in the mucus correlates with its viscosity. So NCF and also other inflammatory lung diseases, mucus viscosity significantly depends on the presence of neutrophils. And in our study population, when we look here at the results, we see that in the sputum samples collected after Simeox, DNA levels were higher than in the samples collected before Simeox. We were now interested if elevated DNA levels in our samples also account for increased viscosity. And therefore, here in this analysis, we plotted the difference of viscosity of the samples of each individual patients against the difference of DNA concentrations within the same samples. And we see here that for most of the samples, there's a quite strong near linear relationship. This also was high significant when we did a Pearson correlation analysis. So taken together, this indicates that higher mucus DNA concentrations are likely to contribute or even cause increased viscosity in our samples of Simeox therapy. We think that a reason for this finding might be that mucus after therapy is derived from different lung areas, probably from areas with higher levels of inflammation. So finally, we were interested how our patients experienced Simeox therapy and asked them to complete a questionnaire. I just want to go briefly to a selection of the questions. So when we start at the top, we see that there was moderate to strong agreement that Simeox can be an efficient form of airway clearance. They were ambiguous if Simeox helps to remove mucus, especially from deeper lung areas. And they all agreed, there was strong agreement, and Simeox therapy was easy to operate, and that they could use the therapy self-dependently. When we come to questions aiming on side effects, no one indicated having pain during the therapy, and only a minority reported some kind of exhaustion or tiredness related to Simeox therapy. Overall, 2/3 of patients, 66%, indicated that they would recommend it also to other CF patients. We also asked as free text style questions what they like most and dislike most about Simeox, and here you see the most frequent answers. So what they liked most, they answered that some experienced better mucus mobilization immediately or within the next hours during the same day, and that they had easier breathing. Some appreciated especially that it is a passive technique which does not require own effort, and that it's easy to use and to operate. When we asked what they disliked most, the most frequent answer was that the device is quite loud and quite large and unhandy. So I think that patients thought about if they would have it at home. So to summarize, we had no adverse events in our study related to therapy, so it appears to be a safe airway clearance method. We found no short-term effects on lung function parameters. However, we found increased diaphragm mobility, better diaphragm mobility after Simeox. The sputum we collected after Simeox therapy was more viscous than the one before, and this correlated with an increase of DNA levels. And therefore, we assume that sputum after Simeox therapy is derived from different lung areas, probably with higher levels of inflammation. According to the patient's experiences, Simeox appears to be well tolerated and easy to use after professional instruction. And of course, to see if there are advantages of Simeox over the established airway clearance methods. Of course, we need further controlled studies also to monitor long-term effects and maybe to identify the subgroups of patients who will benefit most from Simeox therapy. So I thank you for your attention, and I'm looking forward to the discussion.
Thank you very much, Dr. Schmidt, for this very interesting data from an original pilot study. So now we are ready to start the discussion. And Dr. Doušová, any comments to start the discussion, please?
No, I just really want to thank you for very interesting presentations. And if I could comment and ask some questions. So Dr. Milczewska, may I ask you, what is your experience with Simeox in terms of is the Simeox, how is it with the recruitment in your country? And patients available? Is it available for patients routinely, or do you use it just in occasions or during hospitalizations. And as I saw your case presentation, it seemed to be pretty similar to our patient, because our boy was also a little bit problematic with the chest physiotherapy, and he had a problematic social background. And we planned this hospitalization even because we moved him away from the social background, and he improved the cooperation with us. And then as he had some part of muscle weakness and malnutrition, I think the Simeox improved his lung functions much more due to that. So if you could comment on that.
Thank you. As concerned availability of Simeox, we have two devices in our ward, and we use them as much as we can. And we use them also not only during pulmonary exacerbations and intravenous treatment, but also during routine hospitalizations in order to perform routine examinations. And we discuss with, I'm very sorry. And we discuss with patients if it's convenient for them. We train them, then we ask if it's convenient for them. And then we talk about the availability at home. This is not very easy because it's not reimbursed by our National Health Fund. However, there are some rehabilitation funds, and the patients can receive at least a part of reimbursement, so it's partly. And now the more and more patients has Simeox at home, and we have good experiences. Not only with physiotherapy itself, which is obvious, but also we have some patients that are bored with old physiotherapy, and this new, because it's totally new technique, and for some patients it's really very interesting and convenient, and they feel good, and they start to like it and trust it, etc. And also we have some patients that thanks to Simeox and thanks to improving pulmonary function, they also improve their physical efficacy in like you said, in a much more let's say it's general physical efficacy.
Yeah. I must agree on that. We have the same experience, and obviously with the health insurance companies is the same situation in our country.
Mm-hmm.
So the patient has to buy the Simeox, or even we are able to rent them for some small money back to home, and they have it like for 1 month, then they give it back to us and we rent it again or something like that. And are you used to plan these short hospitalization? Is it your routine during the CF care? Are you used to do that? Yeah.
Yes, we have planned hospitalizations once a year if everything's okay, because if something's wrong, it much more often, and it's always 4 days. It has to be for 4 days. It's also linked with National Health Fund, because if it's less, you know.
Yeah.
Okay. But the patients benefit very much from this, because when, of course, apart from this, there are also 1-day visits every 3 months or more often if needed. But during 4 days, we can all the consultations we can carry out peacefully, without rush, and it's apart from examinations, of course, laboratory, pulmonary function tests, imaging, etc., etc. There are much more time for consultants, and very, very important.
Yeah. Okay, thank you very much.
Thank you.
And if I could ask Dr. Schmidt, thank you very much for the interesting results. I would like to ask, maybe I missed that, how long was the interval between the two sessions of the Simeox? Probably I missed that.
Yeah, I did, yeah. So it was between, it differed a little bit between 3 and 6 weeks for most of the patients, so a few weeks.
Okay. And your group was pretty diverse in terms of lung functions and the general status, probably. And what I did not understand, how is it possible that the maximum excursion of the diaphragm changed or increased significantly, but not the inspiration or not the expiration slope?
So yeah, that's a good question. The maximum extrusion of diaphragm, when you look into the literature, it seems to be the most sensitive parameter after such interventions, yeah. And the slope during inspiration and expiration reflects more the time for inspiration and expiration. We measured it because we thought for patients with an obstruction, so there might be a decrease or an increase of the slope during expiration, reflecting faster expiration. And so when obstruction gets better through the therapy, so we see that there's just an increase of the maximum excursion of diaphragm, and this basically reflects a, let's say, deeper breathing.
Okay, thank you. And one could think that the Simeox is increasing the viscosity of the mucus, but did you go more deeply into the results, and did you probably see like increased viscosity of the mucus in patients with worse lung functions compared to the patients with better lung functions?
This is also a good question. So what I didn't say that only about 60% of all the patients were able to provide us with a sputum sample before and after the therapy, because we also had patients who were just non-expectorating. And we had some patients who could expectorate after Simeox, but not before. So this is good for the patient to get rid of the mucus, but we could not use it for analysis. And the patients who gave us sputum sample mostly were the sicker patients with the more severe lung disease. So the number of patients, the cohort was just too small to more go into subgroup analysis.
And are you going to continue in this study, or are you going to increase the number of the patients in this study?
So for now, the study is finished, and we'll think about maybe to do another study to go more into long-term effects with Simeox.
Okay, thank you. So probably if someone else has some questions, now it's time.
Yeah, I would like to ask both groups. So how do you select the patients who offer to try Simeox? Do you just offer to everyone, or just to the very sick patients, or do you have special characteristics?
So in our center, we usually offer Simeox when the conventional physiotherapy is not effective enough. And we are used to offer it for patients with worse lung functions or slowly decreasing lung functions, where we observe even the poor general status and muscle weakness as well. So we think that the clinical effect of Simeox for these patients is much higher compared to patients who are able to perform the conventional physiotherapy. If Anna wants to comment on that.
No, I definitely agree. It's definitely like that. But the thing which is also very important in indications of Simeox is also cooperation of the patient, because without that we can't do anything. So cooperation is also very important.
Okay, thank you.
With us, it's pretty much the same. We, of course, the patient in worse condition, in pulmonary exacerbation, he comes first, let's say. But we talk about most of the patients. We talk with most of the patients about Simeox, and also there are the more and more patients who ask if they can try Simeox during hospitalization, if it's possible, because they would like to try it. They might and maybe have it later on at home. So generally, I think we propose to all kinds of patients, but sicker patients, of course, they go first.
Okay, thank you.
Is it the same in Germany or in your center?
So in my center, we treat both pediatric and adult patients. And so from the beginning, we started to test it more with the adult patients when they come to routine checkups, to routine physiotherapy. And we also have the possibility to get funding from the health insurance for rented devices for home. So we have some patients who really like to really enthusiastic about it and have now a device at home. And as far as I know, they still use it regularly. And in pediatric patients, so we started to try it in some patients, but mostly in adults so far.
One question for all the panel. So it's always a great challenge to slow down lung function decline in CF patients. So what's your success criteria for treating chronic lung function decline in these patients in terms of is it spirometric achievements or other criteria, symptoms, respiratory symptoms? Do you have some targets? What's your targets to help these patients to recover from their lost lung function, and how Simeox can help you to help these patients to recover lung function decline?
So if I got it right, it's about how we measure when a patient has lung function decline, how we measure afterwards if he gets better. Is that right?
I think Dr. Schmidt probably didn't understand properly. If you asked how do we measure the success of the Simeox therapy, how we measure the lung function?
I think
Yeah, absolutely. So what's your success?
Okay, sorry. Yeah, so I mean, you saw it in my results. I think what we're doing, so normally spirometry is the standard diagnostics, of course. We do with all the patients, as well, also with patients who are not enrolled in a study. And so the other things I showed were just experimentally and scientific. So normally we do not do sputum. We do not do sputum analysis or diaphragm ultrasound. This was really just experimentally in our case.
Do you perform the LCI, the multiple Bush-Bristol?
No, we do not in our department. No.
We do.
How is it
in this patient? We had the device out of order because for several months it was out of order. However, on Thursday we will show you the LCI result, and we perform LCI and both spirometry and LCI. I think that it's very important if there is an exacerbation or a decline in lung function, whatever the reason is. And for us, it's very important that it comes back to the period before the exacerbation, so it recovers to the same values from the stable period, and it concerns spirometry and also LCI. on Thursday we will show you the LCI issue.
Yeah, I must agree. It's very individual, and very important is the period before the exacerbation. So, for example, our patient, he was declining due to repeating exacerbations. So he was hospitalized every 3 months almost to get the IV antibiotics. So it's very individual, and to our experience, in most cases, the patients do not recover to the previous values after the declining and the exacerbations. But you saw that in our case report, the patients started to increase in FEV1 trend. So I think that was partially due to improved cooperation and better nutrition status, and many other things except of the physiotherapy and lung functions. Yeah.
Okay, great, thanks. I have some questions from the audience. Very interesting. From your perspective, can Simeox be safely used in patients with increased work of breathing, and especially with oxygen?
I think so, yes, we can use Simeox. We don't have any problem with this because we start Simeox after nebulization. I think so, the most important, very perfectly nebulization, and then Simeox, and we don't see any problem with yes. Yes, so I think so. It's not a problem with Simeox.
To our knowledge, it's possible to use it even in patients with increased work of breathing. We haven't tried it together with the oxygen therapy, not yet. But
yeah, but
why not?
As I understand the device, I think it's aimed or it's targeted to people with increased work of breathing, because comparing to regular, for example, ParioPEP device or device of positive pressure, it needs much more effort to blow into the device. And here, the thought is that it should be easier for the patient to exhale, because it's not forced exhalation. It's more like calm, just to relaxing the inspiration muscles. So I usually use it in the patients with exhausted from like regular physiotherapy. So that's my opinion.
Yeah, I would agree.
One second. Okay, I wait.
Sorry, I would agree that it's not a problem to use it in patients with increased work of breathing, especially that it's a passive technique. This could even be an advantage for those patients, that they can use it better than the conventional techniques. Yes, as the colleague said.
I used Simeox with patient with oxygen, and he was before lung transplantation, and it was a very good experience and very good effects. He swallowed a lot of mucus when he used Simeox, and we used oxygen all the therapies. So it's not a problem for patient, and it was a very good effect for this patient.
The last part of the question was if we would use the Simeox in children with ABPA. I would not be afraid, because usually these patients are treated at the same time with corticosteroids. So the irritability is decreased by the systemic treatment. So I would not be afraid to use it.
Are there any comments on the last question from the Polish team? Do you have any answer to with patients with ABP?
But we agree that we don't see why it should it could cause
the question is
airway irritability. I love the word airway irritability. We don't want to cause airway irritability, so we think it doesn't. But we didn't have any patients with ABPA.
And the thing is that you can regulate the volume of the
Yes.
Oscillations. So
Yes.
you can use the lower oscillations in these patients to prevent the increased irritability.
Yeah, exactly. This is the thing, that when I see that the patient's can be very irritated, and I use just 25% of the power or something, and just I'm increasing it gradually to see if the patient can, during the therapy, tolerate it better, and if not, I just can stay on the 25%. So I think it's for example, in conventional devices, I can sometimes see that it's even more irritating than Simeox.
Okay, great. So effectively, Simeox can be used as a personalized therapy. So the settings can be adjusted, and effectively to avoid to exacerbate respiratory symptoms in fragile patients. Yeah. Dr. Schmidt, I have a question for you. Do you have you tried? Have you assessed with your methodology sonography assessment? Have you made similar data with other airway clearance technique?
No.
Was it first time, or have you any other data?
No, this is the first study we did with this method. So there are, from literature, known some studies basically mainly on COPD. Therefore, we were interested if we can also use it for CF patients to assess changes upon physiotherapy, and of course, further to really assess the effect of one device, we would have to compare it to another device. So this was just a really very small pilot study to see if is there a difference, do we see any beneficial effects, and then of course we further would have to compare to other devices, but we did not so far.
Okay, and how do you explain the potential mechanisms of improved diaphragm mobility with Simeox? Is it a reduction of lung hyperinflation, or due to direct action on mucus? What's your feeling on that?
So of course, it's very hypothetical, but one theory indeed is that it can reduce hyperinflation. So from COPD, there are some studies who correlate parameters for hyperinflation with diaphragm mobility, and they see some kind of correlation. So this is a possible reason for it. Maybe also a reduction of mucus load, so expectoration of mucus plugs can contribute to this. And of course, we did a measurements in wake patients. It was not a blinded trial, so we cannot completely rule out that there are, let's say, some psychological effects on the measurement. So as we had no control group to say, okay, when they had another therapy, we said no difference, and with Simeox we see a difference. So we do not know if there would always be some changes just due to the fact that patients know they are enrolled in a study, and we're looking for their breathing.
So your next step is to to do same evaluation with a control group?
Maybe. Everybody
mentioned that Simeox can be a very good alternative in patients very exhausted, especially that are not able to perform routine chest filter therapy. So for you, it's a good indication to perform Simeox, to use Simeox as an alternative in this kind of patients.
Yeah, definitely it is. And I think we've mentioned that, yeah, it's a definitely very good indication. We have a really good clinical experience in these patients.
Especially in patients, for example, with serious pulmonary exacerbation, which are in serious general condition, very tired, very weak. And it's really important that it's not, you don't have to use much energy to perform it. Because it's during exhalation, right? During passive exhalation. And it's less exhausting than other techniques.
We even used it in patients who are bridged to the lung transplant, and they are usually pretty exhausted. And Simeox could be highly effective in these patients. Yeah.
Mm-hmm. We have to also experience that.
Yeah, we also used it in patients with very severe progressed lung disease, but always in more stable phases. We so far we never used it in exacerbations, but so from your experiences, I think it would be a try to also use it in those patients.
So you highlight the benefits to use Simeox with other therapies, like a combined therapy with other airway clearance device or chest physiotherapy. So from your opinion, what could be the best benefits with combined therapies using Simeox?
We've never used it as a single therapy, just Simeox. So in every patient, we combine the conventional chest physiotherapy with the oscillation PEP.
That's true. I think the thing is that patients are usually used to get rid of the sputum with the device they use regularly. And for example, so many patients we've got here, they are not used to do the therapy with Simeox, so they are not used to cough the sputum out, basically. So sometimes we do the therapy with Simeox, and at the end of the session, we use the device they use regularly to help them to perform their mechanism to get rid of the sputum. So, for example, like that, we can combine the therapy with Simeox and some other device.
I don't know, how is your experience?
So we also use it just as an additional tool. And I think it can be really a great method in addition, but it would never replace, of course, conventional physiotherapy or inhalation therapy. Also, we have to take into account that patients are known to the conventional method since they are children, and so it would be difficult to just change to a completely different system. So we also use it just in addition.
In our patient, we use in our patient we use Simeox and we use PEP or oscillation PEP, and we do on the same session. First Simeox, one session, one series of Simeox, and then PEP or PEP positive, and then 10 or 8 exhalation with Simeox, and then PEP, and we try to do the same under the same time with one drainage in our patient. It's for me it's a very good combination when I can use the different how to say this different techniques. Okay.
Okay, great. Thank you very much for the panel, for this very amazing discussion on the benefits on Simeox. So it's time to conclude. So I would like to briefly summarize our discussion. So Simeox can be a very nice alternative, especially to be used in blind hospitalization, facing with very challenging chronic lung function decline, and Simeox can be a good tool to recover from a lost lung function. the panel highlight the benefit of Simeox to be used in patients, especially very exhausted, that are not able to perform standard chest physiotherapy. Also, Simeox can be also a tool to help these patients to improve their cooperation for using chest physiotherapy and to get the benefits for their disease. Simeox can be used in combination with other airway clearance therapy and to get optimal benefits for the patients. And we had also very nice results from the UN pilot study. It's very promising that explains some mechanisms of how Simeox can help CF patients and especially not only on spirometry data, but to help diaphragm mobility and to also to be able to remove mucus from distal airways and in the most inflammatory parts of the lungs. So thank you very much. I hope all the audience enjoy to listen to these very good presentations. And I invite you to participate to our third European Roundtable on Thursday. And so have a very good afternoon and see you very soon.